Okay, up next, we have Dr. Elanor Watts. She's an ophthalmology doctor based at the Tennant Institute of Ophthalmology in Glasgow in the United Kingdom. She studied at the University of Oxford and the London School of Hygiene and Tropical Medicine, and now works with Peak Vision and the Livelihood Impact Fund to tackle global presbyopia. So welcome, Elanor.
Hi, so just a quick note, which is there was a bit of mixing around of which abstracts were presented which ways. So I'm not actually talking about this. This, though, is available as a poster outside if anyone is interested. But we're talking about a digital tool to guide presbyopia correction. Thank you for the introduction also. So first of all, what did we do and why did we do it? So everyone here will be very familiar with presbyopia as what should be an easily solvable problem, but remains a very large problem, and the different numbers that float around in terms of estimated magnitude. The 826 million number here is the Frick estimate, which is obviously higher than the 510 million VLEG estimate, but as this is what's being used by WHO in the SPECS initiative, this is what we're sticking with. Regardless, there are hundreds of millions of people with near vision impairment just from presbyopia, which shouldn't be the case given what an easily solvable problem it is. As we've said, I'm working with Peak. Silas has already given you a lot of background regarding Peak, so I won't go into too much detail there, but basically, Peak provides software and data intelligence for school, community, and workplace eye programs and offers smartphone-based vision screening, but also data capture and data analysis to make that information more useful. So our thought was, how can we use Peak to help tackle the presbyopia issue? So this is what we did. So to start with, a small group of our team looked at what existing tools are there, what is there to support correction of presbyopia correction, digital tools, non-digital tools, anything. Obviously, you can, in some places, just use self-selection. You might want an optometrist giving a detailed prescription. So there's a whole range of ways to approach this. But we did find that there was a bit of a gap in terms of a simple, easy-to-use tool that could be used by a non-eye care worker to provide presbyopia correction. To see if that's something that anyone actually wants and if it will be useful, we started with an expert survey. This was November 2023 to January 2024 of optometrists, ophthalmologists who have experience in global ophthalmology and low and middle income countries from a wide range of countries, including Nepal, to see what they thought would be useful, whether they thought there was a need. Those results have been presented previously at the American Academy last year, so I won't go into too much detail, but basically there was a general consensus that it would be useful to have something to help people provide presbyopia correction without needing an optometrist or an ophthalmologist, and that would be looking at providing ready-made near vision or reading glasses in particularly low and middle income country settings. We then went from there to look at Peak data that we already had, so large-scale program data for initially 383,000 people, data from 9 countries regarding their near vision, how good their near vision was to start with, what their near vision requirements were, what correction they required was available for a subset of those people. We used linear regression regarding that data to see what influenced what power of correction they needed. Unsurprisingly, the two things that correlated most were age and their presenting near visual acuity, but we found that we got a better prediction if we combined those two factors with an algorithm, and using the combination of their age and their initial presenting near visual acuity could predict quite well what power of reading glasses they were likely to need. That data is available in an article from Eye if anyone wants to see it in more detail, although obviously we're adding data to it all the time. So we used that data to make the algorithm. And then we needed the kind of actual app, the tool that would walk people through using it to recommend reading glasses. That's involved collaboration between a whole group of people. We've got product design, software development teams, and when the little loop, I don't know if you can see the mouse, going round in a circle is because make the tool, try the tool. How could this be easier to use? How could it be more straightforward to walk people through that process, particularly across a range of languages or even within a language, just to make sure everything is clear for someone who's not familiar with the process. So that was the development of the tool. And then we wanted to check if it is actually reliable and valid and if we're making good recommendations. So we worked with Dr. Schroff's Charity Eye Hospital and Shalinda, who is here, yes, to validate this with a cross-sectional study with 378 participants in Uttar Pradesh. And we were comparing the recommended powers by the tool with what would be recommended by an optometrist at a vision center. I should also clarify, although the tool makes an initial recommendation of a power, the process that it walks people through involves trying on different powers and letting the participant, the patient, express preferences of what they can see most clearly with. So it's not just you must have a +2. But we were comparing those two outcomes. We used Bland-Altman analysis and found that the powers agreed exactly in 92.9% of cases and were within half a diopter in 99.5% of cases. The mean bias was 0.012, which, given as we're not giving reading glasses with prescriptions quite that precise, hopefully won't be an issue. And the 95% limits of agreement were -0.3 to roughly +0.3. So in terms of challenges and lessons learned, the main challenges are we've been finding increasingly presbyopia, although initially seems straightforward, is actually quite a contentious topic. There are lots of opinions from all different directions regarding the best way to provide correction, what is or isn't acceptable, and what is or isn't best for people. Other challenges were, as I say, making it usable across different languages, making it a product that is easy to use, and also this grey area of early presbyopes who don't have near vision impairment yet, but might still benefit from presbyopic correction. So initially, I and some of the team were most focused on people who have near vision impairment, so aren't seeing N6 at 40 centimeters, but other members of the team, perfectly rightly, were saying, but what about people who still will benefit from reading glasses, but they can just about see N6 if they try hard? So there were those kind of questions raised. And I think the lesson learned or the solution was to remind ourselves always that we are all working for the same goal, even if coming at it from different angles. So everyone wants to eradicate near vision impairment and also optimize the vision of people who don't have near vision impairment yet. We want to work with optometrists. The point of this app is not to replace optometrists at all, but to allow the provision of presbyopia correction in settings where that's not necessarily available, and to provide as high quality as possible correction. And that for a lot of people, personalized prescription reading glasses aren't necessarily required, and ready-made near vision glasses, if appropriately provided, can correct their near vision impairment. I've been saying we a lot. That's most of the we of the team who've been largely involved in this work. So thank you. And some of them are in the room. Yeah, that's everything. Any questions, please?
This is what many of us are trying to do, or somebody else is piloting. I mean, like staff is doing. So this question is to Dr. Sailendra again. So any outliers that you find, for example, the people who are prescribed, with presbyopic glasses, and if they were identified with any scope of missing in that term. Yeah.
I think Elanor mentioned that briefly. So what happened was that if you go by WHO definition, only thing we standardized here was 40 centimeter. Because WHO says near vision has to be measured at 40 centimeter and N6 is the cutoff. But if you look at those who are getting missed, and that was the discussion always, that I might be N6 at 40, but I want to work nearer to 40 and I will not be N6. So that for the study purposes, we didn't use that because we wanted to standardize, and that is how it can be done, because for a study, you need a standardization. But like Elanor mentioned, for the program, there will be flexibility. So hopefully the presbyopes and the pre-presbyopes or whatever would not be missed that way. But in this research, we were not looking at that. We were looking at presbyopes who are so-called presbyopes at 40 centimeter, not reading N6. So only to standardize the tool.
Thank you. Thank you.
Thank you.